Well, I appreciate the opportunity to tell you about my experience. I'm sort of almost reticent to do this because, except that it was just a first-hand exposure on a very brief basis to something very big, very important that's happening that people sitting here know much more about than I. But I did go as part of the Senior Visiting Surgeon Combat Trauma Care Program. That is really a combination effort of the American Association for the Surgery of Trauma and the American College of Surgeons Committee on Trauma. This is Landstuhl Regional Medical Center. I'll show you where that is. That's me standing across the street, and I put this slide in because behind me you see a very high electrified fence. So I got a little worried when I first got there because they said security is very tight, and when I asked why, they said, well, we think that Ramstein Air Base, which is about 15 minutes away, and Landstuhl Regional Medical Center are really very, very high priority terrorist targets in Europe. And the reason why is really the whole essence of my story to tell is what an incredible job our medical teams, men and women, are doing in caring for the combat casualties from not only Iraq, but Afghanistan, and I found out Africa. And of course, you all saw in the paper, I think only less than a month ago, that they interrupted a very major terrorist attack on the Ramstein Air Base, which is really part of this whole complex. So this is the Senior Visiting Program. Jay, who many of you know, is kind of the person who has been leading this through the AAST. There is a website, and everybody who has gone has been asked to do sort of a debrief of their stay, and so there's some nice reports if you care to look at that website. This is Landstuhl Regional Medical Center. I added this. This was built as a very large hospital by Hitler in World War II, and he had a design where there was no high-rise, was spread out as a deterrent, or at least as a effort to limit the damage control, if you will, in the case of bombing. So this was one of Hitler's hospitals. It was taken over by the Americans when Germany was occupied. And because of this construct, there is about 3.7 miles of hallways, and it's now a much smaller hospital. Prior to the current war in Iraq, this hospital served 95 countries over 3 continents for really the whole spectrum of medical problems. It's now essentially a combat casualty evacuation hospital. I just took this picture one day walking down the hall, and it turned out to be the best map. There's Landstuhl. You can see the rest of Germany. It's only about a 2.5-hour drive to Paris, so it's way over on that southwest border, just so you'll know where we're talking about. I did go under a little different auspices than that senior visiting fellow. I'm a regent of the American College of Surgeons, and we had decided, well, I had recommended, my suggestion was taken, that the College of Surgeons really should acknowledge what was going on. I read these reports. The predecessors of people had gone before. Don Trunke had gone over before I had. Bill Schwab, I think, was the first one to go. And they came back, and the stories were such that kind of reflected a very important thing in surgery going on. So I went really as an emissary of the American College of Surgeons and took with me a certificate of appreciation. This was their grand rounds, which they hold midweek. And this is the surgeon that I worked with principally. Some of you know Steve Flaherty. Steve was a Special Forces surgeon in Afghanistan. He was actually attached to that infamous helicopter crash in Afghanistan where they landed on what they thought was a safe hill, and it was a Taliban stronghold. They got raked with fire as they took off. The helicopter got off, but a Navy SEAL who was half in, half out was left behind. And the credo being no comrade left behind, they actually went back and lost 11 people attempting to rescue this SEAL, who in fact was dead. I mention that because the first day I met Steve, I was in his office, And he's got a gorgeous drawing that an artist did of that day. And this is Colonel Lean, and he had just taken over as the commander of the hospital. And I was going to I'm not as familiar, I guess, as I should be with military. I wanted to present this to Colonel Flaherty, but he was outranked by Colonel Lean, and he jumped up, and all the pictures were taken with Lean. So I waited and took my picture when Flaherty got it. This is what it said. Certificate of Appreciation, American College of Surgeons honors and applauds the dedicated surgical teams. And I really made a point of saying surgical. This wasn't just about the surgeons or just about the nurses or just about any individual. This was about the teams working together there. And they're interdisciplinary, not just specialty, but they're really interdisciplinary inter-service, as you will see, of the servicemen and women. And I was naive, and it says in Iraq. It really should have said Iraq, Afghanistan, and points east and south, because we did have a number of casualties that quite surprised me coming out of Africa. These Marines, I'd say, where were you injured? And they'd say, somewhere in Africa. I'd say, how did you get hurt? I got hurt. Their orders were that Africa was very much confidential information about mechanisms of injury and where people were. So just my little push for the American College of Surgeons, and a lot of people don't know we don't read Latin as well today as our predecessors, but to serve all with skill and fidelity. And I put that in because I thought they lived up to that very well. Sergeant Davis met me the moment I arrived. She was fabulous. She was my guide, and she said, well, you're supposed to have the first day to get over jet lag, but we just had a load of casualties come in, and we hear you're interested in vascular trauma, and we have some of those. And so I was staying in a little hotel across the street. I walked over, and she really put me to work the day I arrived, and I barely got out of town with the last case. I had kind of a fortunate situation in that my tour at Landstuhl Regional Medical Center overlapped with Norm McSwain, who many of you know. Norm had been there with AAST. They ordinarily wouldn't have two there, but Norm was there on the normal AAST rotation, and he and I overlapped for about a week, and he's a longtime dear friend and colleague, and it added something special to be with Norm. So what did I learn? And again, there's people in this room who know much more about much of what I'm going to say than I. So I say it with humility. But one thing for sure that the military that we're learning, those who are taking care of these casualties day in and day out, is that the body armor is very effective, has made a difference in terms of the distribution of injuries, and you'll see that. What we saw, and we were, and I'll show you, I'll take you just through one patient. We were at an echelon 4, and what we were seeing principally, though, were the victims of IEDs, the improvised explosive devices, some large, some small, and the devastation of, you see, just of this one example are just incredible. So knowing that you're all people take care of trauma patients, I thought I'd just tell you about one 21-year-old Marine. He was on foot patrol. He was hit by an IED, went down, had a near amputation of his right leg, had a severe injury to his left leg. Like almost all of those, he had some element of a traumatic brain injury. He described lying still under fire with a medic coming in under fire and putting tourniquets, which we know they're using. I was taught not to. Tourniquets on both legs to stop the bleeding, dragged him out from under fire. He told me that tourniquets were put on while I was down and bleeding to death in the kill zone. That's echelon 1. He was there minutes, really. Echelon 2, he was immediately taken to a forward surgical unit, a mobile unit, where they clearly had experienced trauma surgeon, at least. I don't know the exact details there, but they did a completion amputation above knee on the right and put a javit or a silastic shunt in the left superficial femoral artery, which was injured. And he immediately then, within hours, was at Echelon 3 at a combat support hospital in Balad, Iraq. And there, and this is what impressed me, there he had a very nice repair of an interposition reverse saphenous vein graft for his left leg, his only remaining leg, extensive fasciotomies to Breedmont, and then wound vacs applied to everything, and immediately then transferred by ACS-COT to Landstuhl. And I'll tell you more about ACS-COT, which stands for the Critical Care Air Transport Teams. He was in Landstuhl. This is the day I arrived, and they said, we have a C-17 coming in. We have 10 casualties, one of whom has a vascular injury we'd like you to look at. We immediately took him to the operating room. I didn't know the drill really, and I was ready to go to work. And so I scheduled him to go to the OR, and there were about 6 others going. And one of the other surgeons said, no, Dr. Eastman, you could take him tomorrow morning. And Flaherty, the special forces surgeon that I mentioned, said, no, Eastman's going to take him now, because he is the first surgeon to operate on this Marine who hasn't been under mortar fire. And in fact, I talked to one of our ED physicians who was at this same hospital in Balad during the Battle of Fallujah, and there was a surgeon killed at this hospital. So he was then transferred by ACS-COT to Landstuhl. He was in Landstuhl, where we immediately reoperated to Breedmont. My biggest job, they're so compelled to leave everything open that they leave everything open. So here was this, Raul, here was a saphenous vein graft just out in the breeze. And so my job initially was to make sure the graft was open, which it was, and get soft tissue coverage and complete a couple of fasciotomies, which were not quite enough, and then transferred to CONUS, or Continental United States, on to Walter Reed. So this was the corporal's injury as we got him into the operating room that night with an above-knee amputation on this side. They had closed, I guess we had closed this wound at that point because the vein graft was out in the breeze. And that was his AK stump. And I took that picture principally to show how clean the wounds were. The wound vac, probably one of the most impressive things, was the wound vac. Wayne Meredith at Wake Forest, who knows the plastic surgeon well, who invented the wound vac, this is a real contribution. And every single wound was left open and had a wound vac. As you see here, this is the other leg with a wound vac. This is actually reversed. This is the way it was when he came in with this wide open wound. They approached the arterial repair just through the frag wound. And then I had the opportunity, I was invited down to the Naval Hospital by Christine Hunter, who is the new Admiral Commander, and I understand she's first woman to command a major military hospital. And I was meeting with her about something else, and I asked her if Corporal Gatsby was there, and she said yes, and arranged for me to go over and meet him. And he's there as part of their rehab program. And I sent this picture back to Landstuhl because they never get this kind of follow-up. This was probably the most devastating injury, and I put it in because this was an IED in a Humvee that exploded and incinerated, and 85% total body burns plus complicated fracture on the left leg. We don't even know about his brain because he was unconscious, and he had escharotomies. He went through the same echelons talking about. He came to us with some escharotomies having been done. There were still escharotomies to be done. We took him to the OR and had a team working the better part of the night resuscitating him. He had been in Afghanistan and then went to Balad and then came to us. Again, we saw him, as with the other one, within 24 hours of his injury. Escharotomies like I had personally never done before, and one that I never had done before, just to demonstrate that there are a lot of burns. And then I put this in because when we turned him over, and I must say the escharotomies were all appropriate and done well, and had decompressed everything, except when we got here, and I don't know about you all, but I'd never done an escharotomy of the small back. but that was absolutely tight as a drum. And so I did an escharotomy here, and it was incredible to see. The muscle looked dead when we opened it. The muscle pinked up, and we completed that. The other part of this story is, and again, it's so incredible what is the care being provided. I can't say enough. The team from Brooke Army Medical Center flew over, took over the care. I mean, we just got the hell out of the way because they came in and they knew what they were doing. And they came in with the team. He was the lead burn surgeon from Brooke. He had a respiratory therapist, a burn technician, and a nurse. And they took over this patient, mapped all the burns, obviously. Then they just gowned and gloved, and they didn't take him to the operating room. They just did everything in the ICU. And so you can just see them providing their care. I walked out because I'd been displaced. They rewrote all my orders. I was getting a lesson in burns. I said, this is the way Dr. Coimbra would do it at UCS. We don't care. This was part of their equipment. So they just came. And in fact, we were on the phone with them talking about fluid replacement and so on, because we knew this was a big and a bad burn. Again, Flaherty with the surgeon from Brooke Army, and a woman surgeon who works with Dr. Flaherty. The thing I remember about her is we finished operating all night on this guy, and the next morning she was complaining like hell because she had to go qualify with her 9mm weapon. And we were saying, why do I have to do that? Look, I'm a surgeon. They said, well, we're a terrorist target and everybody has to be qualified. And of course, it wasn't long after that proved to be the case. And then just a couple of other injuries. Again, I'm sure you've all heard about this. This was, again, another patient, obviously, in this case, a left below knee complex fractures on this side. But the thing that I hadn't seen, and in this day of electronic medical records, and you know, you can't survive if you don't have electronic medical records. These were the best op notes I've ever worked with, because there was no question about what had been done and what needed to be done. And just on the tape, they would basically tell us what they needed to do. This was an unusual case in that he had an abdominal wound, remember the body armor, and we're not quite sure what happened because clearly he got hit in the lower leg as well. But on plain film, he did have shrapnel, and the thought was maybe somehow the angle was it came up under the body armor. Fasciotomies laced with rubber bands, and we would start beginning to try to get closure if it seemed appropriate. This was our team. I realize it's kind of inappropriate. This was after operating all night, and we shouldn't have looked so happy, but Norm McSwain looks a little frazzled. But a couple of things I'd like to make sure that I convey. I think the joint theater trauma system is an incredibly important thing that they are doing over there. It has to do with the transport. They have a trauma registry. They have a superb traumatic brain injury registry. They have a video trauma conference program that I'll show you. And the Landstill Regional Medical Center, in the midst of this war, in the midst of getting hit every day with casualties, applied for, were site visited, and were verified as the first military, non-continental United States military hospital to be verified a trauma center. And they are as proud of that as anything, that they are a level 2 trauma center. In fact, this week, 17th, they're going to have a major celebration. I'd have actually been invited to go over and give the keynote at that celebration and couldn't, because I'm giving that border lecture this weekend in Boston, but they are going to have a major military celebration of that. A lot of clinical innovation, and that's really what I'll speak to as I close. This is their PIN, Joint Theater Trauma System. I wanted to get the logo, and I couldn't get it, so I drove over one day with the ACS-COT team. That's ACS-COT. This is an ICU patient packaged and ready to go on ACS-COT. This is a ACS-COT physician and respiratory therapist. Again, they came in, they took over, and now they're Air Force, Flaherty's Army, patients were Marines. It was incredible. I saw one Purple Heart awarded while I was there. I was taking care of a patient. I said, Dr. Eastman, get out of the way. A very large Marine general came in to award the Purple Heart to a Marine that had been badly injured, lost his right eye, had a neck injury. And the most moving part about, so we just stepped aside, and the other survivor of the Humvee IED explosion was his sergeant. His sergeant limped in with a chest tube, with his head bandaged, and he was the one who put the Purple Heart on the chest of his comrade. And I'll never forget it. It was very moving. I was standing there sort of trying to finish rounds, and the sergeant said something to the effect, "War is a terrible thing, Corporal, but what you did should be celebrated, and you're a very brave man." And apparently he saved a couple of the other people and then took the hit himself. And of course that happens every day. They got a big school bus to move the patients now. Remember, Ramstein is about 15 minutes from Landstuhl. So the patients come to Ramstein, they're brought over by bus, they're taken care of at Landstuhl, they're put on this bus, and they're moved back over to Ramstein. And here's a patient being loaded, people in charge. We stand back. There's McSwain staying out of the way. Here's the ACS-COT team, and that's what it looks like inside the bus. They said absolutely no pictures to be taken when you get on the flight line at Ramstein because of security. So I took a couple of serendipitous pictures because I knew Dr. Coimbra was going to ask me to come and give this presentation to you guys. And I thought he'll bail me out if I end up in a military prison. This is a C-17. You can tell the wingtip up. It's converted into a flying ICU. That's a side view, but this is the real view. Again, it was raining like hell that day, so my pictures aren't very good, plus they were very surreptitious. I'm kind of with my camera down here, hoping. And they said, okay, Eastman, we'll let you get on. The flight master, tough-nosed sergeant, said, we'll let you get on. And they got a huge ramp, and they can carry 40 casualties. I'll show you the interior. But he said, be sure and get off before that ramp goes up, otherwise next stop is Andrews Air Force Base in the United States. So I followed that patient that I saw at the Naval Hospital. I went over with him, as it turned out. And I'm standing and talking to him, wishing him well, telling him, oh, you're going to San Diego, I'll try and come and see you. And all of a sudden, I look in the back, and there's this ramp going up. And I thought, geez, I thought it was going to be like, you know, buckle your seat belts and have your seats in the upright position. And, you know, there was going to be an overhead. And I sprinted down and jumped off this ramp, and it was only maybe 2 feet off the ground. And this same flight master was standing there and said, well, Eastman, I was wondering if you're going to get off. He said, you'd have been in Andrews Air Force Base. We would not have put that ramp back down for you. So I said, well, I get the picture. And I don't know where they would have put me, because this is that flight loaded. And it's a little hard to see, but along this wall of the plane are stanchions where they clip in the stretchers. Down the middle is another set of stanchions where they clip in the stretchers. And then all the walking wounded sit on these metal seats over there. Now, this is a 15-hour flight in this big plane. And I think I would have been, you know, right there. So the patient movement really, this is their map, which McSwain and I talked him into giving us one just to show that CENTCOM, the Central Command, so Afghanistan, Iraq, and Africa, really goes to Landstuhl, Landstuhl to Andrews, and then if they're Army to Walter Reed, if they're Marines to Bethesda, if they're Burns to Brooke. And then they do try to get the Marines to Naval Hospital in San Diego as quickly as possible. So I mentioned the Joint Theater Trauma System. This is one other thing that I was impressed with. They told me one day, get over to the room where we're having our trauma video conference. And that's me actually taking the picture of this screen, which ultimately we're in Landstuhl, but we're connected with Iraq, we're connected with Afghanistan, we're connected audio to Africa. we're connected to Walter Reed, Bethesda, Brook. We're all on there, and they just take every patient from the preceding week, and the surgeons downrange, as you know, downrange being at the battlefront, and most of the, and they would talk about what they did, what happened in Echelon 1, what happened in Echelon 2, Echelon 3. They'd say, okay, Landstuhl. And the day I got there, everybody else was operating, and I'm the only one in Landstuhl, and here are all these high-ranking people at these other places. And I said, well, Landstuhl reporting, sir. Wondering if I was going to say the right thing. I would tell them what we did with the patient. Then they would say, we received that burn at Brook, and here's what we have done, and here's how they're doing, and here's what you might have done differently, or the fasciotomy was not complete. Fantastic. And they quickly moved through every patient from the preceding week. They do that every week. I walked through the bookstore on base, and I thought this told a bit of a tale. It's not something we see in our university bookstore and so on, but it's certainly important there. The Military Widow, a survival guide, and on grief and grieving. So there's a lot of psychological trauma that is going on. They, of course, have the clocks, have a typical rounds early every morning. Flaherty leads that rounds, and it's like something you do here every day. The only thing is, it's all the same. It's all young, 18, 19, 20-year-old people missing 1 or 2 or 3 limbs. This was one of our last days. This was one of the highlights for me. This is the Central Command headquarters at Landstuhl, and I was fortunate enough to meet with Brigadier General David Rubenstein, who, and this is the medal he gave me, and it's the U.S. Army Europe Regional Medical Command, and that's his command. And he actually drove over from Heidelberg, and we spent an hour together, and he was sort of thanking me on behalf of his command for what the college and everybody was doing. But this is what I remembered most as we sat in Colonel Lean's office, and Colonel Lean wanted to be part of this meeting. He said, no, we don't need you, Colonel Lean, you wait outside. So the colonel, we're in his office, and he's sitting there. And we had a very nice conversation. But he said, you know, Brent, on my desk, in my office, I have a book by the Mayo brothers written during World War II, and there's a quote in there that the only victor in war is medicine. And we certainly owe everything we are, you in training, those of us who've done it for a long time in trauma surgery, to what we have learned from the military. We did have one night out at the castle. There's a 1300s castle in Landstuhl, and we did go there. So I'll close, Raul, and happy to take questions. I would encourage people to look at this literature. This just is one of the papers. Brian Istridge, Don Jenkins, Steve Flaherty, the people, John Holcomb, who's now in charge of all research. And he's, by the way, going to join our scholarship committee, Raul, and kind of be a liaison with the military. Dr. Coimbra is the newest member of the American College of Surgeons Scholarship Committee, which gives away about $2 million in scholarships every year, and we're really looking forward to him being on that committee. But look what it says. Medical lessons learned from Vietnam and previous military conflicts led to the development of civilian trauma systems in the United States. Absolutely true in San Diego. Dick Virgilio, one of the early trauma surgeons here, came back from Vietnam and made a classic statement that a soldier wounded in the rice fields of Vietnam had a better chance of surviving than a shooting victim in San Diego, with no trauma system, fragmented care, no regionalization. Operation Iraqi Freedom represents the first protracted large-scale armed conflict since the advent of civilian trauma systems in which to evaluate a similar paradigm on the battlefield. And their conclusion, the implementation of a theater trauma system demonstrated numerous opportunities to improve outcomes. And believe me, they are doing that. This is Journal of Trauma, where the 12th Annual San Antonio Trauma Symposium in 2006. And I put that in only to show Brian Eastridge. Comment is the summary of that trauma care continues to be a synergistic relationship between the military and civilian medical systems, as it has for centuries. War is no different and has spawned improvements in injury care that will likely transition into the mainstream of trauma and clinical practices at home. I think that is unequivocally what's happening. Bill Schwab, in his presidential address to the AAST, spoke about the same thing, crises in war. And Bill, I think, said it very nicely that the history of war is the history of surgery and the absolute history of trauma surgery. So I would like, I wish all the people we're trying to inspire to go into surgery and to go into trauma surgery, and it's to me really the future of general surgery and everything you've heard over and over. But I thought I'd go back, way back in history, to Dominique Jean Larrey, who was Napoleon's surgeon from Egypt to Waterloo, and he was praised by Napoleon as the worthiest man I ever met. He is the man that invented the ambulance, the flying ambulance in Napoleon's armies. And so I put that in only throughout history. We've learned a lot from military battles and from war, but the surgeon, the trauma surgeon, no different today than what Larrey was trying to do or Perret before him. You are embarking upon, I think, the future of surgery, the most important aspect of surgery going forward. And I'm just can't tell you how proud I am of what Dr. Coimbra is doing in terms of building this program in San Diego and building on what Dr. Hoyt and before him Dr. Shackford built to train really our trauma surgeons of the future. And I'll close by just saying that this is the slide I showed when I was in Landstuhl, that we think we do learn in our trauma system a great deal, have learned a lot. We did learn from Vietnam, and we are also, just as they are very proud of their joint theater trauma system, I think we all are justifiably proud of the trauma system in San Diego, of which, again, Dr. Coimbra has become really one of the principal leaders of this trauma system. So, Raul, I appreciate the opportunity to give this little overview. There's a lot of people who should be giving this. Besides me, I was only there for about 2 weeks, but it was enough to see what great work these other people are doing. Thank you.
Thank you very much, Brent.